Assalamu alaikum. I'm Dr. Laila Tharwat, lecturer of clinical pathology, hematology. I'm going to give you an overview about the CBC or the complete blood count and the peripheral blood smear preparation and how we can examine this peripheral smear. If we have excessive amount of anticoagulant to the specimen is added, or we have an old blood or long-standing sample for a long time, or if the environment temperature is not suitable to keep the sample for a long time. Preparation of a peripheral blood smear, we have to do mixing of the sample, and this mixing should be gentle. It's not a vigorous mixing to avoid destroying or rupture of the red blood cells, and putting a drop of the blood on a clean glass slide. And we have another thin slide, we call it a spreader slide. Use another this clean spreader slide. We can use it as an angle of 30 to 40 degree angle to control the thickness of the smear by changing the angle of the spreader slide, and then allow the blood film to air dry and to air dry completely before staining. We don't have to do a blow drying or just use our breath to dry the blood film, because the moisture from our breath will cause the red blood cell artifact or the changing the morphology of the red blood cells. Preparation of the blood smear, we have three types of peripheral blood smear. We have cover glass smear, wedge smear, span smear, and we have two additional types of peripheral blood smear used for a specific purpose. The one is prepared from the puffy coat, which is the middle layer between the red blood cell at the bottom and the top layer of the plasma. And actually this one is used when we have white blood cell count very low, less than 1 per cubic 1000 per cubic microliter, or we have another type which we call it thick blood smear for blood parasites. To make it more clear, this is how we are doing our peripheral blood smear. We have two slides. One is called the main slide, and this one is the spreader slide. And then after we putting a drop from the properly mixed blood sample or anticoagulated sample, we have to change the angle of the spreader slide. The angle should be between 30 and 40. We have in certain condition as to do a small angle when we have a very high hematocrit count, and we can do a very large angle when we have a very low hematocrit count. Okay, so this is how we can prepare our peripheral blood smear, and then the spreader slide, we use it to spread the blood film on our main slide. We have here the correct angle to hold the spreader slide, and then spreading the blood across the slide width and completing the wedge smear at the end, which is apparently here. Actually, after spreading the sample on the slide, we have to judge if this peripheral blood smear is good or bad. So what are the characteristics of a good peripheral blood smear? It should occupy about 2/3 of the to 3/4 of the slide. It should be cover of the smear. It is very rounded, feathery edge, having this thin portion, which we call it the feathery edge. It should not be bullet-like. I will show you later how this bullet-like should look like. And the lateral edges of the smear should be visible like this. So this is the optimum peripheral blood smear, and this is a successful one. Also, it should be smooth without any irregularities, holes, or streaks. When the slide held up to the light, the feathery edge of the smear should have a rainbow appearance, and the whole drop should be picked up and spreaded within the smear. Also, repeating again, characteristic of a good smear, it should be thick at one end and thinning out to a smooth, rounded, feathery edge. It should occupy about 2/3 of the total slide area, and it should not touch any edge of the slide and should be margin free except for the point of application. Actually, this is characteristic, and this is how to judge we have a good peripheral wedge smear. Number C is showing the bullet smear, which I told you about. We have thin but tapered middle end. Number B is a jerky one, which is not having not occupying 2/3 of the slide. It doesn't have a thick end and feathery lower end, and actually this is not good smear at all. And number A, you show the edges here as are not smooth, and the feathery end is not good. These are another example of unacceptable smear. You see here the middle one, it has holes on the slide. This may be due to high fat in the sample, maybe unclean slide. We have a lot of causes for this artifact to happen. This one, it doesn't have any smooth edges, and it doesn't occupy 2/3 of the slide, and so this is not acceptable one, and actually number G is not acceptable one. So staining of the peripheral blood smear, as I told you before, after finishing and having an optimum peripheral blood smear, we go to the next step by leaving to air dry and then do staining of the peripheral blood smear. What is the purpose of staining a peripheral blood smear? Is to identify cells present in our peripheral blood or even in the bone marrow, and then recognize morphology easily under the microscope. So we have certain different stain we can use to identify or stain the different cells in our blood or the bone marrow. This stains characteristically whatever its name. The aim of this stain is to be polychromatic stains. What is meant by polychromatic stains? Staining different components of our peripheral blood by different colors, so we can identify these cellular components or these cellular elements. What are the most common stains we are using? Either dry James stain or even another polychromatic stain called Leishman. The peripheral smear examination. The peripheral smear examination should be examined under the microscope. We have 10x lens and 100x lens, and in certain cases we use the 20x and 40x lens. What is the correct area of peripheral blood smear? We have to examine our blood, our slide. Actually, the correct area in which we can evaluate cellular distribution is this area. Area looking like that, where the red blood cells just touching each other. They are not clumping, they are not very highly separated, and we should choose an area with evenly distributed red blood cells and white blood cells just touching each other, not very separated and not very crowded over each other. So how to choose this area to examine our sample under the microscope? Actually, this peripheral blood smear is separated into three parts. Head, which is the most thick part of our peripheral blood smear, the body, which is the area between the head and tail, and the tail, which is the highly thin part of our peripheral blood smear. If we examine the sample or the slide at the head area, we can see that the red blood cell is overcrowded over each other, so it's not suitable to judge our peripheral blood smear from this area. If we go to examine the sample at the tail part, we can find that the cellular components are very separated from each other, so it's not representing our sample properly. But the body, which is the area between the head and tail, where the cells just touching each other or evenly distributed, and evenly separated from each other, which is the suitable area to examine our smear. We have certain morphological changes that can occur due to area of the smear. If we examine at the thin area, spherocytes, which are really spheroidocytes or flattened red cells, can occur or can be noticed. True spherocytes will be found in other good areas of the smear. So it's not suitable to examine the sample in the thin area of the smear, because this can give us a false impression that the red blood cells are all spherocytes. Thick area, if we examine the sample at the thick area, we found rouleau or overlapping all red blood cells over each other, so give us a false impression that it's a rouleau formation or just clumping of the red blood cells over each other. What is the proper pattern of examining our peripheral blood smear? Actually, we can either examine the peripheral blood smear in a zigzag line, and this zigzag line may be longitudinal or transverse. Actually, we can perform whatever longitudinal zigzag line or horizontal or transverse zigzag line. It's like a personal variation, but the most important point while examining our peripheral blood smear under the microscope is not to count or examine an area twice. Why? Because we don't want to have a false count of our blood cells. For example, if I started from this point, I count all the white blood cells or red blood cells in this area and then move forward, and then count here and move forward. So it should not be like counting this area and go backward. No, it should be forward and stepwise, and I have to create my pattern or I have to decide my pattern from to be transverse or a longitudinal zigzag line as apparent here into the figure. So we have certain causes that can cause a poor blood smear. If we have a drop of blood too large or too small, the peripheral blood smear will not be proper. If the spreader slide pushed across the slide in a jerky manner, as I showed you, it will not be a proper or characteristic peripheral blood smear. If we have a failure to keep the entire edge of the spreader slide against the slide while making the smear, so the feathery end will not be proper. If we have a failure to keep the spreader slide at 30-degree angle with the other slide, if we have a failure to push the spreader slide completely across the slide, we will have a very short smear which is not occupying 2/3 of the slide. If we have irregular spread with ridges and long tail edge of the spreader dirty or chipped or dusty slide, so it will not give us a proper. If we have holes in the film, as I told you, slight contamination with fat or grease, cellular degenerative change, if we have delay in fixing, inadequate fixed time, or methanol contaminated with water. So all of these are the common causes of a poor blood smear, and I think the previous figure show you how we can judge if we have a proper or a good peripheral blood smear or not. Biological causes of a poor smear. The poor smear or the causes of having a poor smear, it should not be a technical one all the time, but in certain cases we have biological causes. In other words, that the sample the sample is having certain artifacts that cause the smear is not looking good or not in a proper manner. If we have cold agglutinins, that the certain antibodies that cause the RBCs to clump together, and to avoid this we have to warm the blood at 37 degrees for 5 minutes and then remake the smear. If we have high lipemic sample, the holes will appear in the smear and there is nothing you can do to correct this. If we have a rouleau, the red blood cells will form into stacks resembling coins, and there is also nothing we can do to correct this, but we have to confirm this by examining our peripheral blood smear in the proper area for examination. Next, after preparing and judging the smear, as I told you, we have to leave our smear to air dry and go to slide fixation and staining. And as I told you, the purpose of the staining of our peripheral blood smear is to examine the different cellular component of our peripheral blood or bone marrow, and the aim of this stain is to stain or give a color or different color of the different components so we can identify different cells. Whatever the name of the stain we are using, the principle is to use a polychromatic stain. As I told you, it's a mixture of different components. Our stain is a mixture of different components that can stain different component of the cellular elements with a different color, so we can characterize or identify these cells. The most common stains we are using is Leishman stain or James stain. The Leishman stain is, as I told you, it's a polychromatic stain, and so it's a mixture of methanol, which we can use to fix cells to the slide, and it's a mixture of methylene blue, which is stain the DNA and RNA in a blue-gray color, eosine stain that stain hemoglobin, and eosine granules in an orange-red color, and the pH value should be adjusted by phosphate buffer saline in order to give a homogeneous background. And if you know that if we have a too acidic, it will be a reddish slide. If we have a too basic stain, it will be like a very bluish slide, so it will not be a properly stained one. The staining procedure, as I told you, we have to have the thin smear to be air dried and not blowing with our breath, because the moisture of our breath causing a lot of artifact changes in the morphology of the red blood cells. We have to flood the smear with the stain and stain for 1 to 5 minutes. Then add equal amount of buffer solution and mix the stain by blowing, like we have certain pipettes or something like that to mix this flooded slide with the stain every few minutes, and leave this mixture on the slide for another 10 to 15 minutes, and then we wash off by running water directly to the center of the slide to prevent any residue of precipitated slime. Then stand the slide on the end and let it to air dry again. Actually here, how we can, or this is the station how we stain our slide. This is an air dried slide with a properly separated, spreaded smear, and after air dry we add the stain and the flooding or covering the slide, in the entire slide with the stain, and then after 1 to 5 minutes we add buffer or PBS or just water to dilute the slide for another 10 to 15 minutes, and after this 10 to 15 minutes we wash the slide under running water and leave it to air dry again. And actually this is how it looks like under the microscope, and as the same procedure we judge if the peripheral blood smear is optimum or not, we have to judge if our stain is optimum or not. From the color we can judge that this one on the left side is too acidic and this one on the right side is too basic, so this one in the middle part or number B figure is the properly stained one. So what is the causes, or what are the causes of having too acidic or too basic stains, and how we can correct it? If we have too acidic stains, so we don't have, it may be caused by insufficient staining time or prolonged buffering or washing, which is the second step, or old stain. How we can correct it? By having the optimum staining time or lengthening the staining time, check the stain pH or the buffer pH, and shortening buffering or washing time is just to correct the causes of high acidity. Too alkaline stain may be caused by very thick blood smear, prolonged staining, insufficient washing, or alkaline pH of stain component. So we have to correct it by correcting or checking the pH, shortening the staining time, and the prolonged buffering time. And for sure we have, if it was due to atypical or bad quality peripheral blood smear, we have to repeat the smear again. So the third step in examining our peripheral blood smear is performing a manual differential and assessing red blood cell morphology and white blood cell morphology, because this is actually the aim of having a peripheral blood smear, is to examine this peripheral smear under the microscope after having a good spreaded slide and after having an optimally stained slide. We have to go forward to the examination of our smear under the microscope. So, examining under the light microscope, we have to do like examination first by 10x or 20x lens to just decide which area we are going to examine the microscope, and then go to the oil immersion lens, which is the 100x lens. The 10x or the 20x lens is the aim to examine the peripheral blood smear as if you are looking from a very high area, so you can judge the smear, the distribution, where to decide we are in the body or the tail or the head of the smear, so we can decide that this is the optimum area. And another thing, after deciding which area of the smear we can examine our blood cells, we can go further by using oil immersion lens to see the detailed morphology of red blood cells and white blood cells. So, for the principle of white blood cell examination, we can check for the even distribution and estimate the number present. Also, we have to look for any gross abnormality present on the smear. We have to perform the differential count and examine for any morphological abnormality, and we have to report it. The principle for red blood cell examination, we are examining the red blood cells for size, shape, hemoglobin content, polychromatophilia, for any inclusions, and for rouleau formation or agglutination. The platelets, we are examining the platelet to estimate the number present and examine for any morphological abnormalities we can detect in the peripheral blood smear. As I told you, we are observing first under the 10x lens of the microscope to check if there are good counting areas available free of ragged edges and cell clumps. Check the white blood cell distribution over the smear. Check that the slide is properly stained, and check the presence of large platelets or any platelet clumps or fibrin strands. So these are the importance of having like a screening first of our slide by the 10x lens. And observing our direction. This is a very, very important point in order not to count one area twice. So it will give us a very false impression about the count of our white blood cells or whatever cell we are counting. We have to decide which direction we are going to examine. We can start from here, so we go forward this direction and then go down and go forward in this direction. We never go backward in order to avoid counting one area twice. Observation under the 100x lens. Actually, one of the most important aims to examine under the 100x lens or the oil immersion lens is to estimate the platelets, because the platelets, they are very, very small or tiny organelles. It's like between 3 to 5 microliter. So we are seeing them in clumps. Our eye, we cannot cannot judge one or two platelets. When we see one clump of platelet, I will show it for you later. It's about like giving us that this clumps is between 10,000 to 20,000 platelet in these clumps, and we have to look for 5 to 6 field and take an average. Okay. Also, uh, one of the important things to examine the peripheral blood smear with the 100x lens to evaluate white blood cell morphology, like vacuolation of the neutrophil, toxic granulation, dull bodies, atypical lymphocytes, smudge cells, or hypersegmentation of the polymorph, and whatever abnormality we can see, we have to report. As I told you, the manual differential count is aiming to count the cells when the cells are touching each other. We have to examine the morphology under the 100x oil immersion lens and in a zigzag method, and we have to count 100 white blood cells. In certain cases we have to count 200 cells, including all cell lines from immature to mature, and reporting then after finishing all examining all the different cellular components in our smear, we have to report the results either in percentage or in absolute count by multiplying the percentage by the total white blood cell count. Okay. The red blood cell morphology, we have to observe the size, shape, hemoglobin content, and the presence or the absence of any inclusion. Any abnormal morphology of red blood cell should be assessed and should be graded in certain condition and in other conditions just to highlight or report. Okay, so if we see or if we notice any abnormal morphology in red blood cells, we have to ask ourselves two questions. Is the morphology seen in every field? Is this morphology is pathologic or not artificially induced? Artificially induced, as I told you, by having excess EDTA, by blowing the sample with our breath, by having long-standing sample in our lab before. So we have in certain labs, they have qualitative or quantitative scale to estimate that this abnormal morphology is should be scaled to be abnormal or not abnormal. But actually, if we see, or most properly, if we see any abnormal morphology repeated in more than 5 fields, it should be reported. The normal red blood cell morphology should be approximately the same size as normal lymphocyte nucleus, or two normal size red blood cells should fit the side by side by a normal side polymorph. When possible, we have to report the red blood cell as microcytic or macrocytic rather than simply say anisocytosis only. Anisocytosis, it means like different in size of the red blood cells. We have to be more specified to say that this one is microcytic, which is a smaller size red blood cell than the average one, or macrocytic, which stands for the large size red blood cells than the normal one. When describing red cell morphology, use a specific cell morphology when possible rather than simply reported poikilocytosis. Poikilocytosis is meant that the red blood cells having different or abnormal morphology. So anisocytosis stands for abnormal size, and poikilocytosis stands for abnormal morphology. When red blood cells are normocytic, normal size, normochromic, normal distribution of hemoglobin level, so report as normal. When abnormal morphology has been noted, do not indicate normal on the report form. For example, we have 7 to 10 microcytic red blood cells of oil immersion lens is reported out as 2 plus and microcytic or moderate microcytosis. Certain reports should be as accurate as this, or in different lab just highlighting that we are observing microcytic red blood cells in the peripheral smear. This table just to identify how we can scale the abnormal morphology and say that this is mild, moderate, or marked abnormal red blood cell morphology. For example, if we have 1 to 5 cells per 10 fields, we say that this is a slight degree of abnormality. 6 to 15 cells per 10 fields, this is moderate abnormality. More than 15 cells per 10 fields, actually this is marked abnormality. And actually, we mostly report the abnormal morphology of whatever red blood cells and white blood cells if we have marked abnormality, and we just say abnormal cells are noted in our peripheral blood smear or whatever bone marrow smears, and open our parentheses and describe this abnormal morphology is looking like, and describe what abnormality we are seeing. And also we have different grading for the inclusion bodies if we have rare, few, moderate, and many. Morphology of the white blood cells. After finishing the red blood cell evaluation, we have to evaluate the morphology of the white blood cell in the peripheral blood. The normal peripheral blood smear is having neutrophil, eosinophil, lymphocytes, monocytes, and basophil. Actually, the largest cell we can notice in the white blood cell is the neutrophil or polymorphonuclear lymphocytes, leukocyte, which has 2 to 5 segments, and these segments they are looking like that, and it has a very large size. The eosinophil one, we call it a glass appearance, like it has two lobulated nucleus, or in certain cases 3 lobulated nucleus, and it has characteristic granulation which give the slide or the cell an appearance of an skin of the orange, and actually it looks like an orange brown granulation. The lymphocyte is the smallest white blood cell we can notice in the peripheral blood, and it has a very thin rim of cytoplasm and compacted nucleus in the middle. And actually this normal lymphocyte we use to judge the morphology of red blood cells if they have around the size of the red blood cell. So we are comparing red blood cell size to this lymphocyte. Monocyte, it's like the macrophage of the peripheral blood. So the nucleus is like distorted. You can see like it's like an active nucleus. So certain cases it's like a compacted one, it's like wrapped one, and the cytoplasm is characteristic. We call it either it should appear as vacuolated or a grounded glass appearance because it has a lot of lysosomal enzyme. The basophil one, we call it like as if we have an ink pen and put these drops of inks inside the cell, because it has a characteristic dark blue granulation, and in certain cases these dark blue granulation are overlapping the nucleus, so we cannot see the basophil nucleus from highly dark bluish granulation of these granules. In this slide you can see the different variation of different morphological changes of white blood cell count. Here is the band-shaped neutrophil. The nucleus is like a horseshoe or like a band. This is a segmented neutrophil. This is like the orange-brown granulation, characteristic granulation of the eosinophil. Here is the dark ink dots of the basophil. These are the two variants of the lymphocytes. This is a small rounded nucleus with a thin rim of the bluish cytoplasm, and this is another variant of lymphocyte which has certain granules inside the cytoplasm. This may be indicating that this is a subtype of reactive lymphocytes or whatever. And these are different variants of monocytes having like a ground glass and a pale blue cytoplasm. The stab neutrophil or the band neutrophil, the cytoplasm pink, the granules either primary or secondary, and the nucleus appear dark purple or dense chromatin, and this is one of the maturation stages of neutrophil. This is a band neutrophil under the microscope, and this is how it looks like. This is a segmented neutrophil. The segmentation started to appear inside the neutrophil, having from 2 to 5 segments is normal one, and we can judge if we have more than 5 segmentation of the nucleus. So this is, we can say that this is a hypersegmented neutrophil. Less than 2 segments, this is a band or less segmented neutrophil. This is how the segmented neutrophil is looking like under the microscope on examining our peripheral smear. And actually I would like you to notice that here we are examining in the area where the red blood cells are touching each other. They are evenly separated from each other, and the slide is properly stained because we can judge about the different component, and the different component of the cellular elements are stained with different colors. So this is a properly stained sample. Actually, I would like you to notice here this bluish small dots. It's not like a stain precipitate or something. These are platelet clumps. We have one here at about 3 o'clock, and we have one here close to this segmented neutrophil. These are called platelet clumps. For eosinophil has a characteristic granulation, which is orange-red color, and it has dense chromatin and mostly 2 lobes uh, uh, of nucleus, like an eyeglass appearance. This is how the eosinophil is looking like under the microscope. It has a characteristic red-brown granulation, and here again you can notice this dark bluish dots at the bottom part of the slide. These are called platelet clumps. The basophil, it has dark blue granulation, and this dark blue granulation are very characteristic of basophil. In certain basophilic morphology, we can see that this dark bluish granulation can overcome or overlay the nucleus, so it's a very characteristic appearance. And this is how the basophil is looking like under the microscope. Lymphocytes, we have 2 variant form of lymphocyte, but very characteristic that this is the smallest white blood cell you can see in the peripheral blood, and it is either with granulation. This means that this is a reactive lymphocyte, or without granulation, this is like a non-reactive one. And the chromatin is dense, and actually you can notice that whatever it is, a granular or agranular, the cytoplasm is bluish and very thin rim. This is how the normal lymphocyte is looking like, and it has a very condensed nucleus with a scanty bluish cytoplasm, and the size is very comparable to the normal red blood cell morphology. This is the lymphocyte and how it looks like under the microscope. The monocytes, it has irregular shaped nucleus, and usually it is folded because it is an active nucleus, because as I told you, it's like the macrophage of cell of the peripheral blood, and it has a characteristic ground glass appearance cytoplasm, and it has a very pale bluish cytoplasm. This is how the monocyte is looking like under the microscope. You see, it doesn't have a specific morphology for the nucleus, like it's like a banded or a folded nucleus. And if you focus here on the cytoplasm, you can see that this is a pale bluish cytoplasm with ground glass appearance. Here is very characteristic. You can see that we have a lot of platelet clumps on the right side and on the top part of the slide. Platelet settlism. What is meant by settlism? It describes a phenomenon of adherence of the platelet to white blood cells. It is an in vitro phenomenon of no clinical significance. However, it is important that it is detected since the platelet count will be factitiously low. For example, if we have a CBC for a sample and the automated counter is counting the sample to have a very low white platelet count. Under the microscope, when we are checking or double checking for this low count, we can see that we have a lot of platelet attached here or attracted to the white blood cell. This is a called settlism because we have excess anticoagulant added to the sample, or there is no proper percentage of the sample to the anticoagulant uh, uh, mix it together. So we have to count and say that there is a factitious low platelet count, or we can order another sample if it is possible. Abnormal changes of white blood cell morphology. Here I can show just examples. We have tons of abnormal white blood cell morphology, but I can show you the very characteristic abnormal one. Actually, you have to know that we have a maturation series for white blood cells starting from the immature till we reach the neutrophilic one. So the normal one or the normal direction is going from left to the right. Okay, for having immature cells highly accumulated in the peripheral blood or in the bone marrow, this means like we are uh, in the stage of immature cell collection in the peripheral blood or the bone marrow. So mostly it's a leukemia. So we call here severe shift to the left. If we have high number of hypersegment or of segmented neutrophils, so it's like having a shift to the right. But if we have this middle area by having band neutrophil most commonly accumulated in the peripheral blood, we have here, we call it here mild to moderate left shift. Here, if we have to judge white blood cell count if it is above 10,000, which is usually due to an increase of one of the 5 types of white blood cells. Either we can see if it is this white blood cell count is increased due to high neutrophilic count, high lymphocytic count, eosinophil, monocyte, or basophil, and we can judge or confirm this by examining the blood. Again, this is a different normal variation of white blood cells in our peripheral blood. Here we can see certain abnormal morphology into the neutrophil. Actually, this is a band neutrophil. This is segmented neutrophil. But what is common about all of these neutrophils is highly granulation, and actually this is toxic granulation associated with bacterial infection. Actually, here you actually there is no any segmentation of this nucleus, so this is immature cell, and we have granulation here into the cytoplasm collected to form like this red rods into the cytoplasm. We call it our rod cells. It's a characteristic of acute myeloid leukemia. Here we have hypersegmentation. If you count here, it's 1, 2, 3, 4, 5, 6, 7, 7 segmentation. So it's a hypersegmented neutrophil because it's more than 5 segments. Here we have anisocytosis of neutrophil. We have small size neutrophil and we have a very huge or humongous neutrophil. So this is anisocytosis. We have different sized neutrophil. Vacuolation. Here we have a lot of vacuolation inside the cytoplasm of neutrophil. We have to report it also. Here we have, degenerated nucleus. This is about a cell to die if it is characteristic or more noticed in more than in a characteristic number inside the blood film. We have to report that we have a lot of cells with degenerated nucleus. Dull bodies, you see this bluish inclusion body inside the neutrophil. It's not a dust or something, it's like a remnant of DNA inside the cytoplasm of neutrophil. Here we have no maturation because you see here the nucleolus is apparently inside the nucleus, which is this pale area inside the nucleus. We call it the nucleolus. So this is like immature cell, mostly blast cell, and because these blast cells are very uniform size, very thin rim of the cytoplasm, so this is mostly characteristic of acute lymphoblastic leukemia. Another form of acute lymphoblastic leukemia, the cells are no maturation is apparently here and very thin of rim of cytoplasm, and the nucleus is not condensed like the normal one. So this is another form of acute lymphoblastic. Going back again to the components of automated complete blood count. We have blood count basic parameter, which is hemoglobin, hematocrit, red blood cell, white blood cell, and platelet, and the red blood cell indices including MCV, mean corpuscular volume, mean corpuscular hemoglobin, mean corpuscular hemoglobin concentration, and red cell distribution width. We have also from the automated counter the differential white blood cell count and the reticulocytic count, which are the immature red blood cells circulating in the peripheral blood. These are the indices of red blood cells, including the mean corpuscular volume, the hemoglobin, and the hematocrit, which is directly measured and indirectly measured, and their equations. The reticulocytic count, actually you have to know that the red blood cells is unnucleated cell. If we can see certain nucleated or red blood cells with remnant of RNA or DNA into our peripheral blood, this is called reticulocytic count. This is stained by a type of stain is called supravital stain, which we call it brilliant crescile blue. Okay, and actually we can find certain reticulocytic count up to 2% or 2.5% in the peripheral blood of normal individual, but having reticulocytic count of more than 2.5% in the peripheral blood, this is indicating that this is abnormal, and we have to see the cause of increasing this reticulocytic count in the peripheral blood. Also, we have to report in the peripheral smear or from the automated cell counter report if we have hypochromic microcytic anemia, and we have to screen more for the cause of this microcytic hypochromic anemia and screen for macrocytic causes of if we see macrocytes into the peripheral blood. Hemolytic anemias, it can be recognized by whatever abnormality, and we have to see or screen for the causes of these types of hemolytic anemia. And also for white blood cell disorder, we have to check for leukopenia and screen for the different causes of leukopenias. Leukocytosis, the same. We have to report leukocytosis and check screen for the cause. And here I can show you certain abnormal morphology of the red blood cell. You see here, this is like we called caput or helmet shape or bite cells, red blood cells. It's like a red blood cells with an eaten part. This red blood cell, actually, you see there is empty of hemoglobin 1. So this is hypochromic anemia and even microcytic, smaller size. This one is having like elongated red blood cells. We call it pencil-shaped cell, characteristic of iron deficiency or different types of anemia. It's like elongated red blood cells. We call it pencil-shaped cell. And here is certain type of spiky ends or crenated cells, which we call schistocytes. This is another form, but this is more deep spikes. We call it acanthocytes, most commonly associated with abnormal lipid metabolism. This one we call it teardrop cell. It's like a teardrop. It's very characteristic of microcytic or iron deficiency or thalassemia. Actually, here also we have a lot of bite red blood cells or schistocytes. Okay,